click record. So welcome everybody to our first meeting of the Dementia Knowledge Network for 2024. So Sarah is on annual leave, as I just said, so we'll muddle through in her absence. I'll just kick off with an acknowledgement of country, and then I'll introduce Jeff, who's our guest presenter today. Our meeting is being held on the lands of the Wurundjeri people, and I wish to acknowledge them as traditional owners. I would also like to pay my respects to elders past and present and emerging. So today we have Jeff Brooks presenting to us from PainCheck. So Jeff is a clinical specialist, and PainCheck is a pain assessment tool that allows people without a voice the ability to have their pain recognised and acknowledged. So Jeff is coming to talk to us today, particularly about people living with a dementia diagnosis and how this tool can be of support. So I'll throw to Jeff, and hopefully we'll have an interactive session. So thank you for joining us.
No worries. Thank you, Elizabeth, and hopefully I'm coming through quite clearly and everyone can see me. I will share a screen with you. I'll have a little bit of a presentation to talk through, but I'll give you my background. I am an RN by trade. Been working in healthcare for more years than I like to disclose these days. It's quite a long time. I'm going to ask Elizabeth, are you seeing my screen at the moment?
Yes, it's just loading. Yep.
Lovely. We should be able to see two elderly people walking on a path.
Yes.
And we've got Dementia Knowledge Network meeting date today. Beautiful. So my background, I'm an RN by trade, working in healthcare for around 40 years, and it's been across the whole of the healthcare continuum. I started off in the acute sector, and I came across into the quality side of things, and then into aged care for the last 10 years. I've joined this company, PainCheck, in the last 4 years because I'm really devoted and want to spend a lot of energy looking at best practice in pain assessment for our clients that we have. And I mean all clients who can tell me about their pain, because pain is a really important aspect of our life and social well-being, but particularly for our clients that can't self-report pain. So I'm always, I want to be a good advocate for those clients. In the absence of them being able to tell me where their pain is and how bad it is, I feel that clinicians need to be the very best at reading that body language that they provide to us to give us those subtle clues that that client may be experiencing pain. So my passion brought me to PainCheck. I actually rolled this app out across the last organization that I worked for, and we used it as our main pain assessment tool. So to give you the background about PainCheck, it is a pain assessment tool for residents, our clients, within the community. We also use it in the disability sector. We use it in a fairly broad reaching manner. We're now branching out. We've actually rolled out across most of the aged care homes across Australia as their preferred pain assessment tool, but we're now branching out into other areas of health in terms of palliative care, community care, and even in hospital world, because clients rotate through the health service. They may be in the acute sector, they may be in subacute, they may be residential aged care, they may be in community care. And regardless of where they're situated in terms of their placement within that healthcare continuum, it's really important that healthcare professionals can measure, monitor, and evaluate pain effectively, especially for those clients that can't self-report pain. So PainCheck is an app-based tech solution for that assessment of pain for our clients. It is a TGA-approved medical device, and that's a really key thing to understand. PainCheck, as a company, has gone through the rigorous testing and scrutinization and research to demonstrate the effectiveness of the app, to ensure that it does what we expect it to do, which is assessing the pain for our clients. And the research that's gone behind the development of the app through Curtin University, a university in Western Australia, has demonstrated the efficacy, the reliability, the inter-rater reliability of the app in assessing pain. And that's what's allowed the company to get this sign-off from the Therapeutic Goods Administration as a medical device. So I know apps are quite commonplace within our world, but getting that TGA approval as a medical device is quite a significant one, and it's really one that we're quite proud of. The other thing about PainCheck, it is a point-of-care assessment tool. So it uses artificial intelligence and some AI technology to help us to do better assessments for the clients, but we have to do it with the client there. Gone are the days where a health professional will look at a resident, look at a client, and go back to their computers and record what they think their pain score was remotely and away from the client. You'll see when I demonstrate the app that you really have to be with the client, with them in person, in close proximity, to observe the things that they're doing that may tell you that they're experiencing pain. Again, it's that understanding of their body language that they provide to us as their only mechanism of communicating what they're experiencing, especially for that advanced dementia. So point of care assessment, TGA approved medical device are really two important things to recall. PainCheck comes at the very last of all of these previous pain assessment tools that have been used across the healthcare sector. In 2002, we had the American Geriatric Society's pain assessment tool, and 2003, we had a scale called the Pain Aid Scale. And most clinicians would mainly have used what we call the Abbey Pain Score, which is probably the last tool that's been used widely, but it came in 2004. And in 2004, computers weren't as prevalent as they are now. Smart devices, we probably didn't even have smartphones at that point in time in 2004. PainCheck comes along in 2017 and it incorporates all of this previous body of knowledge, but also taps into the literature about all the things that people do when they're experiencing pain in terms of behaviors. But we tap it into an app that is portable, point of care, and uses the most modern technology to help us to do the best assessment that we can for our clients. And it has that theoretical background. So Curtin University is quite a prestigious university in Western Australia. And the inventors of PainCheck are two key people, Jeff Hughes, who's a professor of pharmacology, and his PhD student, Mustafa Atti, who was the PhD candidate who developed the app. But when they developed the app, what we did clearly is a literature review of all the things people do, and that's what the app's built on. But this clinical testing in clinical settings, including aged care homes that across all of the country and other clinical settings, to demonstrate that the app would do what we expect it to do, which is assess that pain for the client. And it's that rigorous training, that rigorous scrutinization and data analysis and statistical analysis that's allowed the company to get this sign off as a TGA approved medical device. Currently, as I said before, we've got over about 65%, 70% of the Australian aged care market using the app. But PainCheck as a company is now an international company, and we're now just starting off in the UK. We're getting momentum, and we're putting quite a large presence in the UK market. We're just awaiting the FDA approval in America. So once we get that FDA approval, it'll be in the American market. We're looking at the Japanese market. PainCheck will become an international standard for pain assessment for people living with dementia. The next version of the app, just for your knowledge, is going to be for babies in the ages of 0 to 12 months, because they're also unable to reliably self-report pain because they just don't have those language skills and they're way too young. So PainCheck is broadening its scope of practice, but also broadening its scope within the world. But it is best practice. It is going to be a worldwide standard, and it's great that it's an Australian-made product. PainCheck is that app-based tech solution. So it does work on devices such as smartphones or tablets. So whether it's Apple, iOS, or Android, doesn't really matter to us. We have a web portal for organizations to look at their data through open APIs, which is just a computer connection. And we offer training and support for all of the people who use PainCheck. We use PainCheck because it's really about that point of care assessment tool. We want to know what our clients are doing in real time, but also that increased objectivity. So there's been a lot of subjectivity in the past with previous pain assessment tools, which leave a lot of subjectivity incorporated into the assessment, which doesn't really help that overall assessment. But it does, through the app, create automatic charts and trend analysis for any client, but improves clinical outcomes. And really, for me as a nurse, that's what I really want to see. I want to see good clinical outcomes. I want people addressing pain where pain's present, and not treating behaviors or ignoring those signs that a client's giving to me and dismissing it as a behavior that they see with that resident because they live with dementia. I want people to take a step back and take that objective look to see what the client's doing and see whether when we put all those bits of the puzzle together, that we may be seeing a client in pain. And it helps us support clinical documentation. So Jennifer Abbey, who created the last pain scale that we've used widely in the healthcare sector, Jennifer sits on the PainCheck board, and she says this about PainCheck. She says that PainCheck is that evolutionary development of her past work. But of course, now we live in 2024. It makes sense that we incorporate new technology, smart devices, and a bit of artificial intelligence to help us to improve the pain assessment process. Because there are many clients out there who don't have their pain assessed effectively, and that's just not in aged care, that's in the community, that's also in hospitals, that's also everywhere across the healthcare sector. Our common goal as healthcare professionals should be to ensure that no one is suffering unnecessary pain. So it's about using the best tool to give us the best results for our clients. And just to demonstrate that, this is Jennifer's previous pain score. So with the Abbey pain score. So if you're not familiar with this, I'll just describe it, but it asks the clinician to look at a client and listen to the sounds that they make. That's question one, vocalization. And it asks the person to listen for things like whimpering, groaning, and crying. So it does limit to only 3 factors that we listen for. But if I do hear a whimper, for example, the Abbey pain score will ask me, is it a mild whimper, Jeff? Is it a moderate whimper, or is it a severe whimper? But it never gives any definition of what meets each level of severity. So if I hear a whimper, for example, the clinician will go, well, I really don't know what I'm measuring against. I don't know whether it would be classified as mild, moderate, or severe. So they take the very best punt that they can. And that's where the subjectivity creeps into, because I may come along and hear a whimper and think, I think it's relatively moderate, but Elizabeth may come in 5 minutes later and go, I think it's mild. So there's no standardization, there's no clarification about that classification. That's one of the limitations of the previous pain scales that we've had. Whereas the PainCheck app, which is showing on the right-hand side of the screen here, someone's doing an assessment on this resident called Michael. And you can see that the app, through the literature, says that there's 9 vocal traits that a client may do when they express pain. And so the person who's doing Michael's assessment found that Michael was groaning, crying, and talking loudly. And they've marked the little radio buttons on the right-hand side to tell PainCheck as the app that that's the type of things Michael's displaying in terms of that vocalization trait. So much more in depth and much more objectively. So we're not asking anyone to rate how bad we think each one of those elements are. We're just saying, do you see it or do you not? So point of care, that objective data is much better for the client. And we also ask what movement the client's doing when we do a pain assessment. And you'll see that when I show you the app. But it's really important to understand that people will have different pain levels when they move. And a lot of, especially elderly clients, may have underlying disease processes such as musculoskeletal disease, like arthritis, or perhaps rheumatoid or osteoarthritis. They may have other musculoskeletal disease. They may have shingles or neuralgia. They may have lots of things going on. So that change in movement can certainly exacerbate pain. And so it's really important as healthcare professionals that we look to see what pain levels are like when the resident's doing different activities. What's their pain like when they're resting? What's their pain like when they're moving? Is there a difference? Because we do want our clients to be moving freely, as pain-free as we can, because we want them to be mobile. We want them to maintain that quality of life, and that includes their mobility. So understanding the difference in pain levels across different activities is really important. And that's why we incorporate this into the app. Okay, and for anyone that's joined me from any organization, you'll know that we have healthcare, ACQ, SC quality standards to meet. I know they're being revised in July this year. Pain will be a factor in that. PainCheck helps any organization to meet their quality standards in relation to clinical care. I want to show you the app, but I will stop and just ask if there's any questions anyone would like to ask me at this point in time before I show you how the app actually works. No questions? Okay, what I'm going to do, I'm actually going to have a bit of an activity. Rather than just me talking at you, I'm going to ask a couple of questions. So the PainCheck app is built on 42 behaviours that people do when we can't reliably self-report pain because of perhaps advancing dementia. It might be that the resident has got acute delirium. You know, they've got an infection, maybe a UTI, and they've become very confused and they're now unable to reliably self-report pain. So I want you to think about either the last time that you've experienced pain or perhaps someone that you know or love has experienced pain. I'm going to look through the same things we look at in the app. I'm going to ask you to describe to me what type of things do you think you see when we look at these things. And we're going to start with the face. And I'm going to open it up to anyone who is brave enough to kind of share some thoughts with me. But what type of facial expressions do we pull when we have pain? I'm going to record them.
Might frown or grimace.
Yep, absolutely. Lovely. Anybody else got anything else?
Tension, like a tense sort of expression.
Yeah. Lovely. Beautiful. So some really good examples there. And when we have pain, we do have a change in facial expression. That's the one way that we communicate that we're experiencing pain. And as a clinician, when I walk past any client, I can easily pick up that visual clue that they provide to me. But what type of sounds do we make? Think about the sounds that you may make or someone that you love when they've got pain. What type of things do they sound? And you've probably had a bit of a glimpse in the app when I showed you before. But what type of things do you think we look for?
A grunt.
Grunt, yeah.
A sighing sort of sound.
Absolutely.
Moaning.
Moaning, yes. You know, I'm a nurse with 40 years of nursing under my belt. I moan whenever I get up. And, you know, moaning goes with groaning. They're intertwined. I find that they're pretty similar. Some really good ones there. Anything else? If I were to kick somebody in the shin, what would they likely do at me?
Yell.
Yell and scream. Absolutely. Yep, like that.
You might complain if you can.
So what was that one?
You might complain if you can.
Yeah, absolutely. Yep. Lovely. Oh, I could spell, might be better. Lovely. Excellent. So we've got some really good sounds there. What type of movements do you think? And when we have pain, do we move differently? And what would you think that you might do if you had pain in terms of movement?
We might hold the site of the pain.
Absolutely. Yep, if I've got a sore knee, I instinctively will sit down and rub it. If I get a COVID shot, you know, the doctor's given me a COVID shot, I will put my hand over my muscle because it's sore. What else do we do?
You tend to wriggle around a fair bit and
you get restless.
change positions and
yeah. You might get restless. Beautiful, lovely. What about in terms of walking?
Limping?
I might limp, exactly. Or I might have a change in the way that I walk or stand or sit. Lovely. That's pretty good. We're covering quite a lot. What type of behaviours do you think we might display when we have pain?
Agitation.
Agitation, absolutely.
Apathy.
Yep. Apathy.
frustration.
Frustration. And how sometimes frustration vented, do you think? Aggressive behaviour?
Yeah, well, I wouldn't call it aggressive behaviour, but it might be hitting out or sort of trying to protect yourself.
Absolutely. Yep.
Yeah.
Protecting. Absolutely. And I know oh, gee, look at that spelling. Terrible. I'll go back. What about in terms of the language I might display? What type of?
Swearing.
Yeah, absolutely. I might swear and curse. I try not to, but sometimes it does. When I hit my thumb with a hammer, I'll probably drop a few words I shouldn't. Lovely. Good examples. So I'm really just we're just teasing out the type of things that we do and we expect to see that everyone might do, because they are really important. We all do these things. It's just for our clients living with dementia. And when they've lost that capacity of self-reporting pain, these are the types of body language that we really relied upon to help us to understand whether they're experiencing pain. Activities. So what type of activities would we do? And I've put sleep in here. So would you expect to see perhaps a change in sleeping patterns, potentially?
Mm-hmm.
Yeah. So perhaps awake at night.
Restless.
Yeah. Awake at night. There might be restless. And there might be sleeping during the day. Lovely. Okay. And when we have pain, our body does certain things. Now, I always kind of throw this out to anybody that's had the experience of childbirth, especially a natural childbirth. And when you think about that last stage of labor, because that's probably one of the most severe types of pain you'll probably ever have, not that I've ever experienced it, but I used to help deliver babies in a former life. So what type of things do we do when we have that really acute pain in terms of that physiological expression? Has anyone got any ideas?
I've got one.
Yeah.
Kind of hypersensitivity or hyper responsiveness
Yeah.
to things, to touch, sound.
Yeah, absolutely. Oh, let's go on to another page. Beautiful. You'll see we have other things within our app, but you see how we've built up quite a list of things that we might see people do when they've got pain. And I've put you on the moment here, but you've come up with a really impressive list. So thank you. Now I want to look at the app and just see what the app covers off. So remember that the app covers off all of the literature review. So the best thing about our app is that when people use it, they're actually opening up what we call, or opening up a literature review. We just make that literature review into a checklist to say to people, well, these are the things that people will commonly do when they've got pain. What type of things do you see your client do? And so it's a really in-depth, but really objective assessment. And we'll see how in-depth it is. I'm going to log in. So the app sits on your iPhone or the iPad. You log in. I won't go through that process today because that's another one, but I've logged in. And if you imagine I'm working in an organization, I've got access to my organization's data. What you're seeing on your screens here is my dummy nursing home that I've set up for training purposes. And all of my clients here are all training residents. They're not real people. So I log into the app and I find the client that I want to do the pain assessment on, or the loved one that I want to do my pain assessment on. So I'm going to choose a resident called Jenny. So Jenny's on my screen here. She's there, and I press the assess pain for Jenny. So I found my client, and I press the assess pain. Now, PainCheck's smart enough to say, okay, well, we know that the spectrum of people living with dementia is quite broad. And clearly, there are residents living with dementia who can quite clearly articulate their severity of pain and location. That's quite good. So when clients can express that pain, we still have a numerical range score that we would use for that client because they're able to reliably self-report pain. If that's the case, I choose the numerical range score if I feel my client's able to tell me about their pain, and I choose that movement. Are they moving or are they resting? So they're up and about walking, and they might have a sore knee. Maybe they've got arthritis in the right knee, and I'm going to type that body location in. And I'm going to ask them to rate that pain out of 10. 0 is no pain, 10 is the worst pain they could ever imagine. They may say it's 2. So all I do is dial up to 2 and tells me that the client's experiencing a mild level of pain. So if they say 0 out of 10, obviously no pain. 1, 2, or 3 is mild. 4, 5, 6 is moderate. 7 plus is severe. But my client said 2. Jenny told me her right knee's sore, but it's 2 out of 10. So I press save and it saves into the iPad straight away at the very top here. And for people who live in organizations, in a large organization, that data will then float back into their other systems to put that score into their existing kind of workstations. And so it means staff don't have to worry about double handling data or remembering to have to write things into the charts later on. It's all done. Jenny, this time around, is a client living with dementia who's got to the stage now where she can't reliably self-report pain. But we see Jenny doing behaviors day to day. And so we're going to choose the PainCheck. And this is where these 42 behaviors kick in across those 6 areas that we looked at, and we wrote some things. And so I'm going to choose PainCheck for Jenny. And Jenny, at this time around, is resting in the chair. Now, you'll see in the second half of the screen, it says that the face analysis, it's set to, by default, the video analysis. It wants to use the technology within the app to help us to do this first part of the assessment, which is that facial analysis. So what happens is when I press next, it starts using the camera of my device to find my client's face. So there's my face. Imagine I'm not a really good looking Jenny, unfortunately, but about 1 meter away from Jenny's where I stand, and I get Jenny's face on the screen. And when I press the start analysis button on the screen, PainCheck just scans the face, and it picks up all those micro expressions of pain that we know from the literature that people do when they've got pain. So you can see my face wasn't looking particularly pained because I was talking, but it picked up 3 facial expressions. It picked up some cheek raising, some tightening of the eyelids, and closing of the eyes. So that's the automatic scan that we do when we do this video analysis. Now, I think in our Word document, we said we saw things like frowning. So we break frowning down into a number of different areas, and that's why we don't have the word frowning. You can see we've broken up, we're much more in depth than the ones that we saw on our Word document. A couple of key things about this, and it's really important to understand for anybody who is not familiar with PainCheck. As a company, we never store any images of any client throughout the world. So for privacy reasons, when we use the video access on the device to do this scan, all that we keep within the database is the results. So people need to be really reassured that for privacy reasons, we don't store any images of any client anywhere. If Elizabeth said to me, Jeff, can you pull up this assessment that happened last week at a certain place? I can't do it because all I can bring up is what the results show. So it's really important to understand it. I think it's important for privacy to address that. Second thing is residents' glasses or clients' glasses. You can leave them on. We don't need to take them off. And the third part is sometimes residents or clients don't have the capacity to even express on their face that they've got pain, such as people with Parkinson's disease or perhaps stroke, where there may be physiological inhibition of that facial expression. And this is why when we do training, we always talk that the face tells us 9 factors, but it's 9 out of 42. So it's not the answer to everything. It gives me one small bit of information in that big picture of only one of these 6 areas that tell me that the client might have pain. Because my client sometimes with Parkinson's disease may be doing other behaviors. They may be making those vocalization traits. They may be doing movement changes. And they're the things that will tell me that client's got pain, not reliant on the face or not putting an overemphasis on the face. Lovely. Okay, now you'll see on the app, it says swipe left to move through the next screen. We talked about the 6 different areas that we have for pain, and we looked at the voice. And I'm going to just recall what type of things we wrote in our Word document. Okay, grunting, sighing, moaning, groaning, yelling, complaining. Let's see how we go with the app, because I think you've probably got them covered. So we cover things like noisy pain sounds, the residents going ouch, ah, or and we do that. If I'm hurting, I'll often say ouch or moan. Moaning, groaning, you can see there. But you'll see we also incorporate things that you may not initially think are pain related. So again, the PainCheck app is built on the literature that people do when they've got pain. So it's not things we've made up. This is things that the literature tells us people will do when they've got pain. And so this includes things like saying something over and over again, what we call echophrasia. And often, if I go to any aged care facility, I'll often hear a client that might be going things like, nurse, 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 or help, help, help. And so we incorporate that. Even though the client does it every day and staff expect that they do that, the big thing about PainCheck is it wants you to record objectively the things you see the client do without making any assumptions or without making any conclusion that it's behavioral. We just want people to record what they see the client do, because that helps us to put all the bits of the jigsaw puzzle together. But groaning and moaning, absolutely. Crying is one we missed out on when we did our little exercise, which is interesting, but we will cry. If I hurt you hard enough, you'll weep or sob or whimper. But we covered screaming, and that kind of incorporates loud talk, the client that may raise their voice. But we didn't cover howling. And that's, again, interesting because I often walk into any facility and I'll hear noises like this. Ah! And when you ask staff, why is that client making that noise, you'll invariably get the response of, that's what they always do, Jeff. They live with dementia. And we just expect that that's what they'll do. So again, being an objective assessment, we ask people to record what we see without making any judgment. And we sigh. You mentioned sighing, you did very well. And we capture them. So we manually record them. That's not automatically. That's what we manually touch the little buttons to say that we see those behaviors. If I do go through this checklist and Jenny doesn't exhibit any of the above, I just mark the last line. And that just tells PainCheck that I'm not leaving it blank unintentionally. I've looked, just don't see any of those changes. Okay, the next swipe across is the movements. And I'm going to go back to the Word document to see what we wrote about movements. We've got holding the body part, restlessness, and being a bit limp. Let's look to see how the app, we cover much more. Okay, so we cover things like a change in use of arm or leg. So my resident that perhaps, or client that can't, or doesn't have that full range of movement, perhaps they've fallen and hurt their arm. Now they can't feed themselves, or they're having trouble doing up the shirt buttons. That's a change use of their arm or leg. But restlessness, absolutely. Freezing is what we do when we get COVID shots. When we all get our COVID shots, we will guard and we will stiffen up and hold our breath, waiting for pain to happen because we know it's coming. And that's what our clients may do. Guarding, touching body part, we definitely mentioned, but moving away. Again, a protective mechanism, which I think we talked about. If I'm trying to protect myself from further pain, what will I do? Every time a carer comes to me and wants to shower me, I might resist that care and I might move away from them because I'm frightened. I want to protect myself from more pain. But I might change that walking. But we incorporate pacing and wandering. Again, when I worked in that clinical setting in aged care, many of the clients living with dementia would do this behavior. Again, what do we do as clinicians? We pigeonhole and go, well, that's just a behavior related to the disease, without ever stopping or thinking or reflecting that maybe it's because the client's got pain. So objectively record the client's behaviors without making assumptions gives us the best results. Next swipe's behavior. So I think we incorporate a lot of this, and I think going back to the Word document, we'll have a look to see what we recorded. Agitation, distress, apathy, frustration, swearing and cursing. I think we've covered that within the app because what do we see? We see polyatrophy, well, slightly. We say introverted. The person may stay in the room. They may not want to engage in activities. They may just want to stay close to their bedroom and not come out. Being socially isolated. But that verbal abuse or aggression is there, or maybe that protecting, as we called it. But fear of touch is another one. It's really interesting. Again, protective mechanism. If I'm fearful of touch, if I can express that vocally, I may say to Elizabeth, Elizabeth, don't touch me, go away. But if I can't verbalize it, I've lost that capacity of speech. When Elizabeth goes to deliver care to me, I may push her away or move my body back swiftly when she goes to touch me. It tells me that the client doesn't want to be touched. There may be inappropriate behavior like taking clothes off in social settings, urinating in pot plants, etc. But the client is likely to be confused. And so we acknowledge potential confusion within the app by marking confusion, and distress we covered when people are anxious, worried, or agitated. So I'm going to mark a couple here and then swipe across. And we look at activities, and I think within our app, our Word document, we see things like awake at night, restlessness, and sleeping during the day. And we certainly cover that within the app. We have things like resisting care, which I think is a really important one, because honestly, that's one of the things that we see quite often is that care staff will say that the client's, resisting care, refusing showers, refusing to have a pad change. And so it's what we call resisting care. But sleeping for a long time during the day, not sleeping at night time is also covered, and not doing the normal activity. So if a client's just, not quite right today, I can't quite put my finger on what's going on, but I know they're just not themselves, that would be that last criteria, altered routine. The last swipe's the body. You know, what does our body express pain? So we talked about the type of things we do. We might sweat, we might be red or pale, we might be breathing more rapidly, we might be shivery cold. So that's how our body expresses pain. But we also incorporate when clients fall. So important when any client falls and we're doing a pain assessment at home, in the community, or in aged care, whatever setting it is, any fall, even though there's no fractures, even though there's no bruising, can still cause that client a lot of pain. And so we have to be mindful that, you know, if someone's had a fall, then there's a high chance that that's going to be contributing towards pain, and it is. So we acknowledge those things that can cause pain. So a fall, but also wounds, you know, pressure injuries, or perhaps a leg ulcer or some other wound, or broken bits of skin, or a skin tear. And the last one in our 42 indicators is pain from medical condition. In the aged care sector, where I've worked most of my life in the acute sector, most clients that I dealt with had at least one diagnosis of something that causes pain. So rheumatoid or osteoarthritis. It's pretty rare that people don't have something that causes pain, but it can happen. And so certainly, especially younger people with living with dementia, may not have any of those chronic diseases, but most clients are likely. So the PainCheck app adds all of these 42 items. We've done our full assessment. We're going to display the summary, which I'm going to do now. For Jenny, who I've sat and watched and observed the behaviors that she's doing, you can see that each one of these quadrants tells me the score. So the face scored 3, Jenny's voice had 3 items, the movement had 2, behavior 2, etc. But the score at the bottom gives me the score and the severity rating. So each one of those items is rated 1. So we don't weight any item more than any other. We say everything that you saw scores 1 point. So it scores out of a total score of 42. And my resident Jenny scored a total score of 14, which would be a moderate level of pain. So the way that we score within the PainCheck app, if Jenny scored 6 or less, then we would say it's unlikely Jenny's got pain. So I would say that Jenny's got no pain. But when we start seeing several traits, 7 to 11 would be classified as mild, 12 to 15, which is what Jenny's got on my screen here, would be classified as a moderate level of pain. And 16 and above is classified as severe pain. So I'm happy with this assessment. I've captured Jenny's behaviors at this point in time. And if I haven't seen Jenny for a while, I would ask personal carer or a family member who has ever been with Jenny for the last wee while to help me to do this assessment together, to collaborate what we're seeing. But I'm happy with the assessment, so I press save and save again. So the assessment sits at the very top. And then if I'm connected to an organization, that'll go back into the systems for my documentation. If I'm using the community setting, I would use it and document it in my normal process. The benefit of collecting this data for clients is that you can generate reports from PainCheck to communicate pain scores to other healthcare professionals, to the resident's GP, for example, to Dementia Support Australia if they're coming out to see a client because of behaviors, or to geriatricians or anybody else that's having a part of the care of my client. In fact, I will just mention, if Dementia Support Australia do come to see any client because of escalating behaviors, one of the very first things they do when they arrive, they'll get a history and they'll introduce themselves and meet the client, but they'll sit there and they'll do a PainCheck assessment. So it's really important where we can to do those pain assessments beforehand, because instead of waiting for someone to come and review, if we can ascertain whether pain's a contributing factor early, we can intervene earlier and perhaps address it if it is found to be pain related. Lovely. I'm going to stop at this point in time on 45 minutes, right on track. And I'm going to ask anybody if there's any questions anyone would like to ask me about the app or the work that we do within PainCheck.
Thanks, Jeff. That was really interesting. I think that was a very engaging presentation and really clear, sort of comprehensive look at the app. I had a question around who can conduct the assessment. Does it need to be a registered nurse or an enrolled nurse? Yeah,
it's a good question, Elizabeth. Depending on organisations, they'll have their own standard of who does those assessments. The app was designed to be used by anybody. Organisations will tend to go an RN or an EN must do it because that's the level of seniority in our organisation that we want them to do it. But many of my organisations I work with, their carers do assessments. It's delegated to them because they'll often see things that a client's doing before an RN or enrolled nurse will see them. So it's about empowering them. They're giving them, that acknowledgement of the work that they do and the changes that they see. It does take training. The app, may be also released into the future, direct to consumer, for people who have loved ones at home living with dementia and they want to do their own pain assessments. We're not quite at that stage yet, but they're certainly on the cards. But certainly if people are on a care package, then, you could speak to your provider for the care packages about whether PainCheck could be a tool that people could use for that client.
Thank you. Paula, did you want to chime in with a question?
That answered my question, because I was thinking about carers who are caring for as long as possible, and the person with dementia is deteriorating, and it's probably for them, helping them to make some judgments about when to
I think
a doctor or a geriatrician or someone. Yeah,
because often they'll be the first to pick up those things. And sometimes when as a clinician, I might come into a home, for example, Paula, and I might read through the progress notes for the last week for a client, and you can see through the documentation that's been recorded by the care staff that they're telling me all the things I need to understand, like they're resisting care and they're moving away and they're a little bit agitated, and it's like, okay, I'm getting a picture of what's going on. So it's really about empowering them to say, my client's not right, and I think maybe they've got pain. So having that capacity to confidently go to that next level, where it's a case manager or whether it's a team leader, and go, look, could you come and help me review my client? I think they've got pain. I think it's really important. So yeah, the more people on board, the better.
Yeah.
Jeff, is there any way that PainCheck integrates? I mean, obviously, it sounds like integrates with the systems that any organisation has. But say, if someone had been given pain medication or some other sort of intervention, that you can note it within PainCheck to then look at the trends?
Yeah. So within organisations, and I don't know your name, sorry, Naomi?
Naomi, sorry.
Hi, Naomi. That's right. So PainCheck's now looking to see, okay, within a large organisation, for example, some of those organisations will use certain medication software as well. And so we're looking to see how we can tap in and give our data and perhaps even have that cross connection between medication profiles and pain to actually ascertain, especially if I give someone, say, some analgesia like Panadol, because, I've done a pain assessment, I've found a level of pain, I'm going to try something that's in the care plan, some Panadol, PRN. So it's really important to be able to cross-tabulate that data to say, okay, what was the pain score beforehand? What was the pain score after? What was the intervention? So it helps us to kind of pull all that data pieces together. And we are working on that. We have integrations with certain software at the moment, but we're looking to expand that dramatically in this next year.
Thanks.
No worries, Naomi.
Did anyone else have any questions or comments for Jeff?
I was just thinking about health services, and I work in a rural health service, and they don't have particularly sophisticated systems, and they're not necessarily well integrated. There's so I'm just wondering how practical it is, and probably a little bit about the cost, to be honest. And
so we do have a number of clients that just are in that boat. They're small providers, maybe a small hospital. They're not they don't have electronic medical records. They're pretty much paper-based, which is fine. The app can be used as a standalone. So I suppose it's about making sure that you can document that pain score somewhere within your medical records. It's probably the most important thing, and that can be achieved quite easily. And so that's not normally a barrier. We just work with whatever client's got. If they're sophisticated, got lots of systems that we integrate, great, because that does make it a bit easier, but it can be used as a standalone. We've done that for many, many clients. In terms of costs for a health provider, it varies. And so I'd have to kind of point you in the direction of my sales team. But the overall cost, for an example, for a client in aged care, it'd be less than a coffee a week, like a month, sorry. What we charge is about, is less than a coffee per month.
So is the cost based on sort of how many people you are using?
In the residential aged care setting, Paul, and that's probably what we use mostly. It's on the licensed bed numbers.
Yeah.
Hospital settings are completely different because you have a rotating number of beds, and so again, I'd probably steer anyone towards my sales team if they wanted to try it in that hospital setting.
Yeah. Thank you.
But I think it's worthwhile. And when I joined the company, I remember speaking to the CEOs about, whilst we had a focus on aged care because we knew that was a high population of clients that needed it. I've worked in the acute sector, and I used to work in the general medical ward. And I know that half of my clients in that ward were people living with cognitive impairment. And they all predominantly came from the community. Some came from residential aged care. But in a hospital setting, lots of challenges in terms of the setting, and so I couldn't honestly say we gave the best care to those clients because we just didn't have the best tools. But they visit us for a period of time because they run well. It makes sense everybody's on the same page using the best tool that we can, and not using things like risperidone or quetiapine for medication for behaviour control, when we should be stopping and looking whether that client's got pain.
Yeah.
Sounds like I'm talking to the converted, Paula.
No, I'm thinking while you're talking, and I'm thinking, so say in a hospital setting where you would have a mixture of people who can verbally rate their pain, as well as some people who can't, for instance.
Yep.
It could be used for everyone, and it's just about which button
it's all about which tool. Because many of the clients I've nursed over a long period of time in the morning are really good and able to clearly articulate pain, location, and severity. But by 3 o'clock in the afternoon, that may be a completely different picture. So as a clinician, I make that judgment of what's best for that client at that point in time, and I choose the appropriate tool. I know many clients, even in no matter what sector, that they're fine until they get that sepsis, that UTI or chest infection. They become quite delirious. So again, PainCheck just allows you to use whatever tool is best for that client at that point in time.
Yeah.
Jeff, I feel like you've said this, but say if it was a person living with younger onset dementia at home, their care partner, can it be purchased individually?
Yeah, at this point in time, Naomi, we're not direct to consumers. At this point in time, it's something that the company is looking at down the track. It makes sense, but we're just not quite there. I think we're just trying to work on how we might support them because, when we deal with an organization, we're dealing with someone who's central and coordinating that care. When we've got individuals, it's about how do we train them up on the use of the tool. It will happen. The next version of the app will be the infant version, which will be for anyone with newborn babies between 0 to 12 months, because they also can't tell us about pain. And we're looking to go directly to market for that product. So I would say watch this space. I think it will get there.
Yeah.
But I would say, if someone's got a community care package, then they may, if they wish to, go back to their care provider and say, look, I've heard about this app. Is it something that, as part of that care package, that can be explored in terms of incorporating that care into my loved ones' activities or care?
Thanks.
No worries, Naomi.
Thank you, Jeff. Any last questions, comments, feedback for Jeff? No. Thank you so much, Jeff. That was really informative and quite an enjoyable session. So thank you for such an engaging presentation. Really appreciate your time.
My pleasure, Elizabeth, and hopefully I'll see you in person next time.
Yes, I hope so. Lovely to see you. Thanks, everyone.
Thank you.
Take care.
Thank you.
Thanks,
Bye-bye.
everybody.
Thank you very much.